Another cause of pelvic pain due to muscle or is patients who have endomyometritis. This patient had a previous delivery. She's 3 weeks postpartum. She has fever, pain. Obviously, you're wondering about infection. And were there any inciting causes? Well, she had manual removal of the placenta, which again has a higher incidence of infection. You can see she has some fluid in the endometrial canal and a small amount of air. So that's another cause. And again, just ask the patient what's going on, and she tells you the diagnosis. Patient who had a therapeutic abortion now has a vaginal discharge, small amount of fluid in the endometrial canal. The uterus was tender to palpation, and so she also has endometritis and some degree of myometritis, giving you the uterine tenderness. One of the questions you might ask is there any evidence of retained products? And in fact, there was none in this patient. So what other causes related to the myometrium, not the endometrial canal, but the myometrium, adenomyosis is a very, very, very common cause of pelvic pain. Misplaced IUCD, another cause. And as I said before, fibroids, almost a non-existent cause of pelvic pain. Adenomyosis is not fibroids. You see it every single day, but you have to look for it. For the longest time, we weren't making the diagnosis of adenomyosis, and in fact, we were calling everything fibroids. Well, a fibroid is a well-defined, distinct, big white mass that displaces myometrium, whereas adenomyosis is a diffuse infiltrative process that invades the myometrium. So they're really totally different conditions, but you have to know about it, you have to think about it, and in fact, the diagnosis is very, very common. So, typical characteristics of a uterine fibroid, often seen in women who have never been pregnant, but obviously you can see it in women who have been pregnant. It's a well-defined, discrete mass that you can see here. It has a hypoechoic periphery that, in fact, is often associated, that is associated with compressed myometrium. The density can vary from decreased to the same as myometrium to increased. Cystic changes are uncommon. There's peripheral vascularity, there's distal shadowing. The fibroids are non-tender, and they can have calcification, but often late. So here's another example where you can see the ultrasound and the pathology specimen. It is a well-defined mass, compressed myometrium around it. Here you have that well-defined mass with compressed hypoechoic myometrium, and behind it there's this diffuse shadowing behind the fibroid. Here's a fibroid that in fact is a cornual fibroid, seen in a number of different images, and this particular fibroid was tender, and I don't know exactly why. I find it unusual. On the other hand, typically adenomyosis is the cause of pain, and here is a beautiful example of an adenomyotic uterus. So it's often found in patients who have had previous pregnancies, but you can see it in nulliparous women, in women who have never been pregnant. It is an ill-defined asymmetrical thickening of the myometrium. You can see the anterior myometrium is very thick compared to the posterior myometrium. The echogenicity within that myometrium is mixed. There are small cysts. They're very common, more common in the second half of the cycle. And even 3 millimeter cyst is abnormal and a sign of adenomyosis. You have central rather than peripheral vascularity. You have this irregular shadowing or streaky shadowing seen behind the adenomyosis, and there is tenderness, often focal tenderness, and they don't calcify. Here is an interesting patient where she had adenomyosis. I did a hysterosonogram. I put in a balloon a catheter with a balloon in the endometrial canal. I injected saline, and you can see on a magnified view the what appear to be ducts extending into the myometrium, and in fact these ectopic endometrial glands in adenomyosis do connect to the endometrial canal. Some of them give you cysts in the myometrium, but most of them will connect to the endometrial canal, and you can see them on hysterosalpingogram or sonohysterogram. Remember, in this pathologic specimen, you can see that diffuse heterogeneous pattern within the myometrium, very typical adenomyosis. The cysts within, even in the subendometrial portion of the myometrium, are actually dilated ectopic endometrial glands. Clinically, adenomyosis is seen in women over 30 years old who have had pregnancies. It causes menorrhagia, often with clots. They have pain. The pain can be unexplained, can be throughout the cycle. It can be associated with menstruation. And the uterus is tender. Tender during intercourse to give dyspareunia, and similar tenderness can be elicited with the endovaginal examination. So check it out. Ask the patient, when you're pushing on the uterus, say to the patient, does this hurt? Don't just assume because she's not complaining or whatever that it in fact is non-tender. Push on the uterus and say the words, does this hurt? Now obviously if the uterus is tender, but also the adnexa and bowel and everything around in the pelvis is tender, then it's not going to be a focal problem of adenomyosis, but may well be a generalized program such as endometriosis or pelvic inflammatory disease. When you see focal myometrial densities, some people have called this scarring, but in fact it's not. This patient has diffuse heterogeneity in the myometrium, and these small echogenic lesions are in fact collapsed subendometrial myometrial cysts. This is all adenomyosis. Here's another patient with multiple densities, and these are very small subendometrial myometrial cysts. It's all adenomyosis, and here you can see this patient has another adenomyotic cyst. It's all adenomyosis. Another patient has a grouping of small cysts, giving you those focal densities. This isn't calcification because there's no shadowing behind it. So there is these small focal densities. It's different in patients that have densities secondary to calcification in fibroids. Here you see calcification with dense distal shadowing, and on X-ray, of course, this patient has a calcified uterine fibroid. So the small focal densities of adenomyosis are different than those of calcified fibroid. Here's another patient. She's 52 years old, she has menorrhagia, and look at that myometrium. There are cysts, there are holes throughout the myometrium, there's areas of increased and decreased echogenicity, and the uterus was tender. This is a transmural extent of adenomyosis, extensive adenomyosis. So all of the typical features, and remember, this is adenomyosis. Adenomyosis is very, very common and a common cause of pelvic pain. What's important is look at the whole package. Look at the patient's symptoms. If they have bleeding, clots, pain, tenderness, and dyspareunia, then this is very, very important. Then look at the sonographic findings of asymmetrical thickening, cysts, heterogeneity of texture, and streaky shadowing. And finally, on the ultrasound physical examination, they have focal uterine tenderness. Well, if in fact if they have all three of them, adenomyosis is almost for sure. 2 out of 3, it's probable, and 1 out of 3, they can still have adenomyosis, but it's not quite as certain.